Thank you so much for joining this breakout. Delighted to have some of your time today and to have this panel conversation. My name is Maria Kalina. I'm the Executive Director of the California Collaborative for Long-Term Services and Supports. Really long name. We just call ourselves the California Collaborative for short. And if you haven't heard of the Collaborative before, we are a membership organization. There are about 60 members that participate, including LTSS providers, health plans, labor unions, consumer groups, and so we have a really broad perspective. We also have a really phenomenal regional coalition network that spans 46 of California's 58 counties. I've been in this role since January 2023, but prior to that I served in a consulting capacity for the Collaborative since its inception in 2011. And even further back, I was the senior project director for a small Sacramento-based nonprofit that really focused on bipartisan and unbiased policy education. And we worked a lot in healthcare policy and social determinants of health. So this has really been a passion of mine for a long time and continues to be in the aging space as well as other spaces. I'd love to introduce our panel, and I think we'll start with Ellen. Ellen An is the Executive Director of Korean Community Services, or KCS for short. It's a vibrant and dynamic multi-service FQHC that provides health, educational, immigration, legal, and social service programs in Orange County. Something you won't get from the bio sheet. Ellen has been a resident in Fullerton for over 20 years, and she was named the 2019 Woman of the Year by the California State Assembly for her work and also for her engagement in the community. Next, we'll go to Pat. Pat is the Vice President of Policy for the California Hospital Association. She has a remarkable 25 years experience in hospital and healthcare management in both acute and post-acute settings. And at the California Hospital Association, she provides support and advocacy for hospital-based post-acute care and case management services. And I will say, for many years of interacting with Pat, she is like a well of expertise in this particular segment. Lydia joins us today wearing two hats. She is the Interim Executive Director for the California Association of Adult Day Services and also serves as the Executive Director of the Alliance for Leadership and Education, known as ALE, which works to advance innovations such as the community-based health home model. Lydia has enjoyed a 35-year career in public policy and program development in the fields of aging, mental health, and disability. And last but not least, someone I'm really proud to call a friend, Carolyn Nava is the Systems Change Manager for the Disability Action Center, or DAC, which serves 8 rural counties in Northern California. She's also the chair of the Diversability Advocacy Network that's currently conducting a series of listening sessions, promoting the region's newly designed Aging and Disability Resource Center, or ADRC, and supporting the Far North State Local Master Plan for Aging Advisory Committee. She's a busy lady. So our panel had asked me to just do get a little sense of who's in the audience. And so I'm wondering how many people here are from the LTSS or Enhanced Care Management Units or sectors. If you could raise your hand. All right, 1, 2. Welcome. Just to kick off the panel discussion, I want to acknowledge that California is an incredibly diverse state. Geographically, our communities look different. We have a vast diversity among California residents. And focus populations, stakeholder types, experiences with CalAIM implementation have also been very diverse. And so just to kick us off, I'm hoping that we can kind of ask each panelist to give us some insight into what has this CalAIM implementation journey really look like for you. And maybe we can start with Lydia and maybe work our way down. Does that feel right?
That feels great. Okay. Hi, everyone. Welcome. Glad you're here. In my leading our organization of adult day health care / community-based adult services, which is the Medi-Cal term for this benefit that's been around actually in California for more than 30 years. We were one of the first states in the nation to adopt this model of care. I've been through many system changes. I live in Sacramento, I work in Sacramento, I'm a policy wonk, and I'm passionate about aging and disabilities and have been for my whole career. None has been more impactful in my experience than what we are trying to achieve, all of us collectively, through CalAIM. And we're all learning together. I want to underscore that. I think my colleagues will as well. And this is both a tremendous opportunity, but also creates tremendous risk. Not necessarily risk for you all in this room, maybe your company, if all does not go as planned. But at the end of the day, the risk is our beneficiaries, our members, our participants, as we call them, who are the subject of this grand experiment, and I call it an audacious experiment, that we are trying to shift the culture and the operations of what at its core is what? An insurance company. You're a managed care organization, but your core culture is an insurance company, right? Talk about risk and reimbursements and probably spend $1 gazillion trying to figure out finances every year and negotiating with the state and others. And I'm always reminded that at the end of the day, this is about the member, the participant, the beneficiary, and that drives everything that I think about and that I do as I work with my small provider community. For those of you who don't know what the heck adult day health care or CBAS is, I'll refer to it as CBAS since that's the Medi-Cal lexicon. This program is not well understood, never has, because it is not part of the traditional healthcare system. It hasn't been for all these years until recently, when it has been enveloped now by managed care. It is a benefit under the 1115 waiver, and despite the governor, Brown at the time, and our current governor, Newsom, trying to eliminate this program completely as a Medi-Cal benefit, here we are today, still around and still dedicated to serving these high-risk older adults who precisely meet the definition of who we're focusing on through CalAIM, and particularly through enhanced care management and community supports. So we're proud to be a partner in all of this, and we're proud to be partners with managed care plans because we've been doing this for long-term care. I like to say we invented person-centered, team-based, community-based care more than 40 years ago. And I want to share with you guys something I haven't shared with my panel when we were preparing for this, and that is this model of care was designed not by some wonks in an ivory tower somewhere. It was designed by community nurses who saw a need in serving the patients they served, where we could do things better and we could do things outside of an institutional setting and improve quality of life for folks. So that's our driving force, and our touchstone is doing that. And CBAS is an alternative to isolation, loneliness, and unchecked decline for people for whom society often overlooks. And we have proven that people can successfully age even with many chronic conditions and disabilities through the end of their life without ever setting foot in a long-term institutional setting. We serve 40,000 duals. That is the focus, as I'd like to say. And the other thing I'd like to say is think about our healthcare system in California, right? We're the 6th largest economy. Someone can fact check me on that. It changes, it seems, year to year, but we're somewhere around there. And we're changing the public health delivery system for these most high-risk beneficiaries under a waiver that's a demonstration, and we want to do it, we have to do it, because CMS says we have to do it in 5 years. Yes, we had CCI, that was the precedent and all that, but It's an audacious experiment, and we're all learning. I want to underscore that. And so we are experiencing problems. We'll hear more about that after we come back to questions with Maria. And I do want to share some of the challenges that we're experiencing with you a little bit more. Let's see, I wanted to just say one more thing. I guess more on a kind of wide lens again before we get down to more detail. Not only are you all trying to figure out how to operate within this CalAIM environment, our community-based organizations, among them I include my colleague Pat, who's part of the hospital, but who is also passionate about serving people in the community. We're also trying to figure out how to interact with managed care, because you are a system we haven't interacted with historically. So that creates a whole other level of complexity, and because we have 20-some managed care plans and everyone's a little bit different, you can imagine what that involves in trying to be partners with all of you. So I'll stop there and turn it over to Pat for her kind of wide lens.
Well, thank you, Lydia. You really spoke to my heart, and I hope folks in the room, about the role that our collective system, plans, hospitals, community-based providers, should be working together to meet the needs, in particular, of older adults. So I am from the Hospital Association, and hospitals, as medical providers, our primary role and the historical role people think of us providing is care and treatment, medical care and treatment to individuals when they have an injury or illness. But I think it's really important for our hospitals and all of us to recognize that that's not where the care stops. It doesn't stop at the hospital walls. When a person leaves the hospital and goes to their next setting of care, that's not really the end of their medical care, and it's not. They don't go automatically from medical care to social care. It's really should be viewed as not only a step in the journey. It's not only the patient has recovered and they've gotten their medical care, but as a part of that journey. And that's, I think, where historically hospitals have not done as good a job as we could. And I think that's one of the challenges and real focus areas, opportunities and challenges of CalAIM, is to take a look at that care transition process. What happens in the hospital happens in the hospital, but it needs to not stay in the hospital, to borrow a term from Las Vegas. What happens in the hospital should transition into the community. And what that really necessarily means is we need to pay much more attention to that transition process, to the support that a patient or a person is getting once they leave the hospital and start on their journey to getting back to home or a community setting whenever possible. So when we need to really think about moving from a medical model of care. Hospitals are a medical model of care. We have a patient in a bed and we're doing stuff to them to fix the problem that they have. But the patient isn't the problem. Once that problem is addressed, we need to work with the patient to figure out what they need to be able to return to their home and their community. One of the areas that I'm most concerned about when it comes to CalAIM implementation, and I think one of the areas of challenge and opportunity that Lydia alluded to, is this focus on coordinating care, not only, well, let me take a step back here. I think one of the other things that I get very concerned about is our current system is very focused on serial care, what happens in each level of care, and we talk about care transitions like there's just two sides to that care transition, when in fact, from a person-centered standpoint, that step is just one step in a long journey of recovery, and hopefully getting back to as high a level of independence and community residential care as possible. So we need to stop thinking about our care as happening in discrete settings and there being a transition from one step to the other. And CalAIM is really one of the first avenues we really have to do that, to take that patient from this level of care to the next level of care in consideration of what might happen down the road for that patient, what their overall goal is. It's not just about getting them from a hospital to a SNF bed. It's about getting them to the hospital to a SNF bed where they can get the therapy services and support they need to return to their home in a few weeks' time. I mean, that's just one example of a care journey. It can take, as you know, all different kinds of routes. So I think the two areas of CalAIM, as we've been trying to address these initial months and years of implementation. One is that communication and coordination with the plan's long-term care for this patient, access to the right level of care coordination, whether that be ECM, transitional care services, whatever. So hospitals understanding how they can start the patient on that journey with their care coordination manager, or how the care coordination manager can help move that patient through their recovery journey. That's one area. But another area that I'm particularly focused on is access to care that helps improve functional status. You know, as hospitals, we focus on medical stuff. You know, we focus on whether or not we addressed that infectious bug or we took that tumor out. And the outcomes and things we're looking at are, you know, often based on lab results and whether or not we got all the cancer or whether or not the person recovered from their pneumonia. But what we don't pay enough attention to historically or ongoing is the individual's ability to care for themselves. Rehabilitation services, which is the area I spent most of my clinical and operational career in. When a patient leaves the hospital and you ask them what they want, well, yeah, I want my blood levels to demonstrate that my diabetes is under control, but what I really want to do is be able to go to church and to see my friends. And that really requires a shift in our focus in both the medical settings and the social care settings, where we are inclusive of those support services, including skilled therapy, but also caregiving support that enhances greater mobility, greater ability to perform activities of daily living. Those are the things that for our older adults are critical in helping them move from the hospital to the home and stay there and be able to age in place. Readmissions to the hospital are more highly correlated to mobility and ADL factors than they are to any particular diagnosis. And yet, in CalAIM, I haven't seen that brought to the forefront as much as I would like, especially in the context of how the long-term care carve-in is developed and so on. So I think that's an area, the two areas I would say that we really need to focus on in our CalAIM journey in terms of hospital care and our work with the plans, and is keeping the patient at the center. And access and communication among and between the various care coordinators throughout the whole time of that patient's journey, and emphasizing access to rehabilitative care. When it comes to older adults, there's a lot going on in the hospital world. They've recognized this. There's a lot of movement toward age-friendly care with greater attention toward mobility, ADLs, nutrition, sleep hygiene, all of those kinds of things. But those are also things that we need to be focused on throughout that patient's journey from the hospital to home and so on. So the two areas that I think I'm most interested in delving into and working with the plans on is ensuring that patients get access, especially older adults, to the functional therapeutic support and equipment that they need to be as independent as possible, which will allow them to age in place and be as healthy as possible. Got more to say about that, but we'll have more opportunity to talk. I think right now we're really focused on the Medi-Cal population through the implementation of CalAIM, but part of CalAIM also seeks to expand the role of Medicare Advantage and D-SNPs, which is another area I think that we need to really focus on in terms of patient access to care. I think that's about it for now. I got plenty more to say, but I could keep going.
I'll circle back. I was jotting down what you were saying and some questions that I can, if we have time, we'll circle back. But Carolyn, do you want to kind of give us an overview of what your experience has been with CalAIM implementation in the rural North?
Interesting. I'll be as brief as I can, because there's, as Pat just mentioned, there are so many things we could say from this platform. But what stood out for me in this moment and listening to my colleagues was two words that Lydia mentioned a moment ago, and that was audacious experiment. And when I think of the word audacious, I'm a wordy, okay? I'm kind of a wordy, techie, arty. We'll talk about that later, okay? But the word audacious in my spirit speaks to something that's courageous and something that's bold and something that's new and innovative. And then you have the word experiment, which translate for me a learning experience. So what I think about in this CalAIM journey is a bold and courageous learning experience from every single side of the table. Now, in my role as an advocate, as a systems change warrior, I'm going to use the term and branch off into Ellen, but as advocacy warrior for an 8-county region, that's literally geographically a little more than 1/3 of our state, the territory that we cover in our capacity as a center for independent living. So there's a lot of diversity, a lot of differences, a lot of change happening on a daily basis that we track, and we say, how do we begin to integrate this? Mainly, this is a learning experience, CalAIM, and we are learning a lot. What we are definitely learning is what we still require to bring to the table in this conversation. We're sitting up here with decades of experience in this cause for better health care. Okay, I can remember 20 years ago teaching for the California Partnership for Long-Term Care in state classrooms for financial advisors with continuing education. And you've seen the bios, okay? This is not a new conversation. So what are we missing in this bold and courageous experiment? Because that's what we're having out here. And what we want to really take to our heart is that the test subjects, it's not the care plans, it's not the corporations. The test subjects in this experiment are you and me and every single person that we service out there. So our goal is to become closer to that understanding of what we require as humans. We've been talking about this DEIB and, and equity and race and all of those things. As a human species, are we really so different that we even have to have these conversations? So we're going to start getting real, I hope, with this table today so that you can bring this heart back to your community and understand what you require in your neighborhood to make this bold and courageous experiment something positive for the subjects that you service.
Hi, everyone. I actually want to focus on the first two words, advancing equity, because that is why I'm here. Just a little bit about myself professionally. I run a federally qualified health center, a community-based organization. We have about 8,000 patients, and the majority of them are monolingual Asian immigrant seniors. Let me place my county. My county is Orange County. Orange County is the 3rd largest Asian county in the nation, the 2nd in California. And there are nearly 1 million Asian folks who live in Orange County of different language ability, but really the Asian immigrant population started in the 1970s. So when we're talking about the elderly, you are talking about people who are immigrants and who are not fluent in English and who mostly worked low-income jobs, who paid into the Medicaid system, and who are now beneficiaries of the system. So that's how I'm going to just place myself. As an organization, we've been implementing CalAIM. We are very lucky in that we are in a county, a COS, a county-operated health system. County, we have one plan, CalOptima, and we have been an early adopter of ECM and 2 community supports, the trifecta of housing supports and asthma remediation. And those have mostly been focused on Asian immigrants, including seniors. It's been, we can focus on problems, but it has been mostly, for me, cathartic. It is a payment system that pays for the work that communities of color have been doing for centuries, people helping people navigate through the system and getting resources for people. It's helping your auntie or your neighbor because you speak English a little better. And it's now paying for that. So despite all the issues and the systems, I mean, any new system is complex. It will take years, perhaps a decade to iron out. But for the most part, it's been amazing because we now get paid for the work that we have done for free, many immigrant communities, for many, many, many years. Just a little bit about myself. I am the child of low-income immigrants. I, from probably second grade, from when I could read and speak English decently, I've been reading my parents' letters from the government. I've been their interpreter. I have been what now they call a community health worker, but the informal care manager for my family, and then all the uncles and aunties that immigrated after my parents, all mostly low-income immigrants. I went off to a good school, did what a good Asian daughter does, and here I am getting paid as the executive director running what I did as a child. And so that's when people talk about lived experience, and in the earlier plenary session, they talked about community health workers becoming C-suite. That is me. And so that's the perspective I bring to this. It is amazing to see that my aunties and uncles at my church, who the pastors' wives types, they now have a pathway to a professional job, and they're doing what they've always done. It's just now a part of the system, and it's recognized, and there's dignity to their work. And so for the most part, I mean, we can talk about the nitty-gritty of CalAIM and how, but for the most part, for immigrant communities, this is a tremendous opportunity to really, at the end of the day, CalAIM is about getting to value-based care. It's about getting to better health care, and this is an opportunity for communities of color to become a part of the system, to really move forward value-based care, as well as to move the metrics in healthcare, because Lord knows they haven't moved for a long time. So I want to end with what I started with: advancing equity. For me, that's very simple. My dad, who was an immigrant pastor, low income, lives in a mobile home. My mother-in-law, who ran a small kiosk, a 1-hour photo kiosk, they paid for decades into this system that is now paying for their Medi-Cal benefit. And CalAIM is an opportunity that pays people like me to build systems that can really assist them in their final phase of life, whether it's navigating LTSS, navigating their healthcare provider, navigating the community supports. And so that's the perspective I bring to this panel.
Thank you so much, Ellen. And I think you and I have similar experiences being immigrants, coming from an immigrant background. I serve as my parents' advocate when it comes to healthcare. It's reading the stuff they get in the mail. It's trying to help them understand their health bills. And I think ultimately CalAIM is this marriage between healthcare and social services. And I think at the same time, while we're creating this marriage of the two, we're also trying to create a system where we don't necessarily need advocates to have good health outcomes, that the system works for those individuals of different backgrounds, different experience levels. So I do want to circle back. I think I'm going to jump around a bit. And Pat, I know you promised to give us a little bit more background on some of the challenges and experience. I'm sorry, Pat, Lydia.
Oh.
Some of the challenges that adult day healthcare centers have had in this experiment of moving towards CalAIM. And I know that you probably were going to talk about workforce and building provider networks. And so maybe I'd like to give you a couple minutes to just expand on that a little bit and share, what are the necessary services and supports that older adults need, and how do we move towards that in respect to our workforce and building that infrastructure and that provider network.
That's a lot, Maria.
I know.
So, and I really appreciate Ellen's comments and Carol and all my colleagues, because we have successes we've seen so far. But I won't lie to you. I mean, I'll be honest. There are still significant challenges. And Ellen is blessed to be working with one health plan in a county that knows her really well. She's an FQHC. What we struggle with in our community to serve our participants, who are largely duals, 98%, 99% of them are duals, and many are immigrants, non-English speaking, live alone, check off every risk factor you've ever read about, and we meet it, is working with multiple health plans. How many, I'm gonna ask, how many here are from San Diego or LA County? Okay, so you know whereof I speak. Even though we're supposed to have core, similar metrics, data, and so on, I'm here to tell you that ain't the way it's happening out in the field. There's a lot of differences among the plans. So that's one big challenge, is figuring out. So those who have ECM contracts, who have community support contracts, are still learning and navigating and figuring out how to work with all their insurance companies. That's been a huge challenge. Our community is excited about CalAIM. I've got early adopters, right? You all know people like that. They're the first to get the new iPhone, et cetera. So we have early adopters in our community of providers who really jumped into ECM because they saw in it a way, as Ellen said, to get paid for what they'd been doing for free for all these years and getting no recognition from the healthcare system or others. So given that, another challenge has been compliance with all these new rules and so on. And I want to just say one thing. There's been a huge contrast in the experience of our provider community. And I'm just here to share not my own lived experience, but my experience in talking to providers every single day who tell me about beneficiaries and them. And that is the difference between how they're perceived and treated as regular old CBAS providers and how they're treated as enhanced care managers or community support providers, and the amount of investment that's going into that. It's really been a shock to them to see the difference. They didn't know what it could be like. They didn't know what it could be like. So I just leave that message with you all to think about it and take back. The other challenge you mentioned is workforce. I don't think there's anyone in this room that hasn't heard about workforce challenges, and certainly my colleagues here struggle with that every day as they work with their own staffs and with hearing and working with other community partners. It is a huge, huge challenge. And at the end, I'm going to leave you with this, but I'm going to say it right now. I really think it's incumbent on managed care plans to invest today for access tomorrow. Because if we don't do it today, guess what? There will be not enough community providers to achieve what it is we're all trying to achieve. They are dropping like flies right now. Pat and I can attest to the closures that we've witnessed that should have never happened but for the lack of investment. So that's another huge challenge, and you've got to be able to pay people what they're worth. And that $25 an hour healthcare bill that just passed isn't fully implemented yet by any means. Boy, do our staff know about it. They read about it, and they want that $25 an hour. Our centers can't afford it. Our centers can't afford it. Do you know what nurses cost on a registry these days? North of $100 an hour. You can't even open your doors to serve people on any given day if you don't have an RN, not an LVN, an RN. So there are those kind of challenges that I think collectively we really need to work on. We can't do it alone in the community, and you guys certainly can't do it alone. You've got to work with with us and others and advocates to make sure we've got access to care, not just for today, but for tomorrow. Because this population's aging, guys. I don't know if you've heard. It's aging. I'm doing it every minute. I call myself a partial dual because I am on Medicare, but unfortunately not on Medicare. But I do have a child who's on Medi-Cal, so I do kind of get that. So I'll stop there, but
Yeah, and
we could talk for a
Pat, I
long
don't want to
time.
put you on the spot, but you shared some stats with me that are just, for me, it really speaks to this challenge that we have in transitioning folks out of the hospital and the lack of community providers. But Pat, you recently, the California Hospital Association recently did a survey looking at how many hospital beds have folks in them that don't need hospital level of care, and the number was just staggering. So I'm wondering if you can kind of support what Lydia's saying and just kind of expand on it a bit.
Yeah, I think before I get into the specific numbers, I think it is important to identify that this is a lot of what Lydia was talking about, that we have workforce challenges, we have different levels of the care that either haven't evolved to meet the needs of the patients that we're serving, and we need to make those investments, or some of the levels of care that could help our patients are for whatever reason not accessible to our individuals. Our hospitals really are facing a crisis in being able to transition folks from one level of care to the next. It is a crisis. It's a long-standing problem. We've always had issues with particularly very complex patients who have a lot of coexisting conditions, being able to move from the hospital to a community setting, whether that be a long-term care residential setting or some kind of home-based program with support services. It's always been a problem for certain very complex problems, and the case managers I work with can tell you that they have faced this for many, many years. But in the past several years, it has gotten much, much worse, and really having significant impacts on hospital capacity, on patient access to care, post-hospital, and ultimately on outcomes. So the survey that Mariah mentioned, we just published it earlier this week. We asked our hospitals throughout the state to identify how many people are in your beds today that should be at another level of care. Not pointing the finger that it's necessarily because we don't have enough SNF beds or we don't have enough authorizations or the patients don't have homes. Those are all factors here. But we found that, conservatively speaking, that on any given day there are about 3,000 people in acute hospital beds that should be in another level of care. 3,000 patients. Now, 1 million patient days a year. And those are patients that, and I shouldn't even be calling them patients because they shouldn't have to be patients anymore. They should be somewhere else. But these are folks that, for whatever reason, can't leave the hospital. When you think about it, 3,000, that's several good-sized hospitals. That's several. Our hospitals are what, 200-300 beds a lot of times. That's several hospitals. We estimate for those 3,000 patients, we require at least an extra, I should have had these numbers off the top of my head, but it's like 1,500 extra nurses. 1,800 extra licensed nurses are needed to care for those individuals. Because if they're in an acute care bed, we're staffing it as an acute care bed. We have to. So talk about a workforce impact. The hospitals have to keep people on staff and pay for them at very high rates for them to be in hospital beds. The other thing that we're finding is that it's really, at this point, it's escalated to such a point that we're seeing capacity problems. Patients are backed up in the ED because they can't go upstairs to an open bed, because the open bed is taken up by somebody who should be in another level of care. I mean, it's very much a throughput issue that affects every level of care. So, maybe some of our population or some of our community may think, wow, those poor folks that are stuck in the hospital, good thing I'm not a dual old person who needs special care. Boy, it's too bad for them. But then when they go to the ED and they have to wait an extra 10 hours, which is an average extra delay, because the ED is backed up. So it's creating an incredible thing across, an incredible issue. CalAIM has the opportunity to help with that. It's by no means, there's many things that need to happen. Do we need more community-based residential care facilities? Yes. I hesitate to say we need more SNFs. Perhaps we do, but I also think we need alternatives to individuals that might not have to be in a SNF. And that's where CalAIM and ECM and transitional care services and population health management can really help. But we have to get away from what we discussed before, looking at things just by setting of care and focusing at one step in the process at a time. We in the hospital setting need to be laying the groundwork for that person to move to a higher level of independence, which means doing things in the now to help that happen, but also means that somebody is helping and supporting that person all throughout the level of care. There's an incredible access issue. Some of the access issues are related to not enough housing. We do have issues with prior authorization. We have access issues in particular to rehabilitative care services, either in the SNF setting or an acute rehab setting. And as you heard me talk about before, I have particular concerns and passion that is something that is penny wise and pound foolish not to provide the level of rehabilitative care that many of our folks need. When elders stay in the hospital too long, it's bad news. Elders, especially older adults, their mobility deteriorates, their orientation changes, they're much more likely, there is a very real thing called hospital-acquired disability syndrome, very real. It can have cognitive implications, it can have physical limitations. If a patient spends a week extra in a hospital longer than they needed to be, they'll probably never get their full function back if they're elderly and have comorbid conditions. So again, I thank you for letting me get on my soapbox with that. But I think the very, very important things for us to be thinking in the long term, not only in terms of the investments we're making for our workforce and our sites of care, but also think in the long term about how a patient moves from one level of care to the next and make sure they get what they need every step of the way. That's what CalAIM really provides us a structure to do. So now we need to work together to get there.
Thanks, Pat. Thanks for letting me put you on the spot about the new report, too. Carolyn, I think what the perspective you bring to the table is that of a community-based organization, traditionally a social services provider, independent living, and you've had this experience of onboarding, building relationships with your managed care plan, getting CalAIM on the ground. And so I'm wondering, from that experience, can you share any insights about supports or what's really needed to better alleviate, build relationships, onboarding, smaller CBOs, others that are sort of following in that path to become a member or a provider in CalAIM?
Absolutely. First, I would say patience. Because if you're a community-based organization, you're possibly not used to stepping into the medical model. You're not used to the world of billing. You're not used to the world of PAs, right? Mm-hmm. So you come from a very different place and a very different language. And I think it's on the part of both sides of the table to understand how to bring some congruency to the languages and the vocabulary. So step one is do what you require to do at your side of the table to understand who you're speaking with and how you speak with them in order to help them understand who you are and what you do. I'll give you an example. It took our independent living center more than a year in application time to help the managed care plan understand that the language we used for the transition process from a nursing facility or a hospital to back out into community-based living, the language that the Department of Rehabilitation uses was completely different from the language that was used by the managed care plan. And so we're sending in pages and pages, and when I say pages and pages, I mean more than 172 pages of documentation to show that we knew what we were doing after 44 years of doing it. That should not be that difficult, okay? There must be an easier way. when we were asked to come to the table as a community-based organization, and Ellen and I talked a little bit about this in the planning stage, we didn't do this because of money, okay? We received $120,000 to service 8 counties. That's nothing. That wasn't even enough to hire a qualified person to help with billing because none of us do billing, right? So this wasn't about money why we came to the table. We came with the spirit of doing what was right for the community. We require these additional services. We require the expertise of community-based organizations like Ellen works with every day. You know, those smaller facilities that do the real work without the language bureaucracy, okay? So first of all, just be patient with the process. Second of all, be persistent. Be persistent. So 3 Ps, okay? Patience, persistence, personable. Because if you get ticked off, game over, okay? So you got to keep your calm in all of this. Yes. And you got to just remember that we're all humans looking for the same cause. CalAIM, we talked about this in planning. CalAIM is an amazing vision, okay? The vision is real. We all want that in our hearts. What we now require to do is to roll up our sleeves together and look at real human-based implementation. Okay, there's always money for the vision. There's never money for the implementation. That's what we require to work through together.
Okay, and I know we're getting close to time, but I feel like I have at least 2 more questions. So, and then I want to turn to you all and see if you have questions. So I hope you're able to bear with us. But Ellen, I know, you know, first I just want to kind of underscore, Carolyn, what I heard from you, which is relationships. And you have to have patience in relationships and kind of persevere through that. And I want to kind of turn to Ellen and just ask sort of a similar question to Carolyn, which is like, what are the tools that you need to have or you recommend folks have in their arsenal as they take on integration into CalAIM? What will make that journey smoother from your perspective?
That's a tough question, but I think it all depends on where you're coming from. And I'm going to skew the question a little, if that's okay. Yeah. Carolyn talked about being ticked off. I am a little ticked off at times. I think for those of you who are here, you are interested in elderly services in one way or another from some perspective, and you all will or do hold positions of power and in your small and large worlds, and to really get to where CalAIM needs to be, and to get to a place where equity is realized in elderly populations, is to really look inward. Equity seems to be the flavor of the month these days, and I've been doing this for 30 years, kind of being my community's warrior. I have been the token Asian woman on so many different boards and things. It is what it is. I also have seen people hire one Asian person and then equity box checked, and we're done. This CalAIM is an opportunity because it is an influx of resources to really look inward and say, am I perpetuating inequity by tokenizing this issue, or am I really trying to practice equity at all levels, including the C-suite, including the people who make the decisions, including, where the funding lands, or am I doing this as a self-interest and perpetuating inequity? So I know I'm a little on my high horse, but I think as we look at elderly care across all the different industries that impact elderly care, we all need to look a little inward, because this is a tremendous opportunity, an influx of resources, and a way to transform a system. And so I don't know if that fully answered your question, but I did want to get that point across.
I love that. And I actually, maybe I'll turn back to you, Ellen, and pick on you a little bit more. Equity is sort of at the center of this vision of CalAIM. But often, and I love asking people, how do you define equity? How do you define equity? Because I come from this place of administering programs where, you have to have measurable outcomes. You have to know what you're working towards, and then you have to measure how well you're achieving it, right? Like that's the area, the place I have been. And I love asking people, how do you define health equity? How do you know that we've achieved it? To me, it feels like a moving target, like we're still learning. But I would love to hear from all of you, actually, what are we working towards? What does it look like? How do we know that we've gotten there?
Yeah, to me, it's really simple. I mean, as I was thinking about this, I was thinking, if I moved to Italy and had to work as a low-wage worker because my degrees don't matter, and then I aged in Italy, and my Italian is just not that good, and I have to read a piece of paper with a gajillion words, what would that feel like? And what are the systems in place so I get the same level of care as every Italian out there? That's the shoes that a lot of people, whether they're immigrants or they're folks in the criminal justice system or all the populations of focus that we're looking at, that just don't have that one leg up. What is that care that we are actually delivering? Once we say it's the same, then that's equity. I mean, it's as simple as that. So we're not there. We're not there. It is not the same across California. That's why we see these disparities. I wanted, my organization and another Asian organization, we vaccinated all Asian seniors, tens of thousands of people, because the system was not ready. And we lived through a pandemic that inordinately affected the elderly. And it laid blatant. Even something as simple as access to vaccinations. If you did not speak English and could not navigate some app, you had no access to. And so to me, equity is just really practical.
Here we go, right? Let's just take the data, because I'm also a data person, right? And when we think about the state that we live in, and we think about the population. I'm an African American woman, and I live in a state where 6% of the population is African American. Now, in that same state, a disproportionate 26% of all homeless people are also African American, okay? Next in line, tribal, Native American, Indigenous, coming in at 12%. So we're still land miles, double the next group in line, okay? So we all know the statistics in relationship to housing insecurity and health care, okay? Thank goodness I'm housed. There was a time in my life where I was absolutely housing insecure and lived on someone else's living room floor for the better part of 6 months until I could save up to find an apartment for myself and my child, right? So this is real life that we all come to the table with, lived experience. Like Lydia mentioned earlier, I also have family members with behavioral health challenges, disorders, schizoaffective disorder. There's no cure for that. That's my brother's everyday life. My mother was bipolar. There were times when I felt like I was the only sane person in the house. But like Ellen voiced, we grow up in an environment that somehow contributes to the passion that we bring into our adult life. So that lived experience now causes us to talk in a way and walk in a way that maybe becomes the impetus for change, okay? So this is about making the change. The center that I work with, the Disability Action Center, 8 counties, 50% of our county coverage territory. Well, actually, 4 out of 8 counties hail on the national census poverty area, okay? It's a very poor region, but I will tell you, at our center, the most common person walking in the door is a 60-plus-year-old white female housing insecure. Mm-hmm. So what is my vision of equity? It goes beyond color, it goes beyond culture, because we are all human. So my vision of equity means no matter what you look like, no matter what language you speak, like Ellen said, healthcare is the same.
I'm really digesting the perspectives that you two just provided. That's wonderful insights. I think from my standpoint, what I become more tuned into when it comes to our current discussions of equity is, especially as we talk about older adults, kind of the intersectional nature of it, that the people come to our needing our services from their worlds, and when they're older and they're part of a disenfranchised population and they may not be non-English speaking and or they're disabled, I think one compounds the other, and we need to be, it can't be focused on individual attributes, because when those different attributes come together, it can be devastating. We know that older folks is one of the older individuals, people over 55 or 60, is one of the highest growing populations that are becoming homeless. Yeah. And we know there's a lot of people on the streets that are disabled. And so I think when we talk about equity, I've learned a lot in the past couple of years from my colleagues about it's not about just evening it out and making sure everything's the same for everyone. We really do need to focus our efforts on populations that are, for whatever reason, disconnected, and we need to bring some targeted work into our work on creating an equitable, not vanilla, all the same for everyone. People should be able to get the same level of care, but we need to target our efforts to acknowledge the differences and the challenges that many of the folks that come to us for care have.
I'm just going to say three things.
Yeah.
3 words.
Yeah.
So I think to sum up my colleagues and our thinking, I think we're all in alignment, and probably many of you are as well, but it's about choice, having a choice of services that fit your needs at any moment in time in your life. It's about access, having the services available, and it's about person-centered. So being able to address a person's cultural, language, disability, strengths, and so on. So I think those are the 3 sort of themes that we've elucidated here.
Thank you all so much. At this point, I think we're standing between you and lunch. So what I would like to ask is if our panelists can hang out for a couple minutes, and those that want to go and grab their box lunch, absolutely feel free. I'm just going to wrap up with some housekeeping items. But if you want to stick around and you have questions, please feel free to do so, or you can corner us later on. So I'm going to skip this slide. We can come back to it. ITEP has asked us to remind everybody about evaluations. I have planned plenty of events myself. I know how important that feedback is, and I know that ITEP also strives to just do the best they can. And so any sort of commentary, feedback, things you like, don't like, all of that is incredibly helpful. And please let us know how your experience has been at this conference thus far. ITEP is hiring. So if you're in the market, you're looking for a job, there's a QR code, and you can scan that to learn more about the opportunity. They're looking for a new director of policy. And lastly, there's some social media information. Follow ITEP, engage them on Twitter or X nowadays, Facebook, LinkedIn. And with that, I just we'll go back to question slide. And if you have questions, please raise your hand, and I think Shirley will come around.